Good morning, everyone. This is Dr. Lawham, and this is your preface for our class discussing management of patients with coronary vascular disorders. We're going to basically cover the patho and clinical manifestations in this preliminary pre-lecture, if you will. A lot of these things you have already had in your other courses, and so basically this is dusting off the cobwebs in your mind about these different things, the differences and the similarities, so that you'll be ready to come in and talk about the diagnostics, etc., and move into nursing care of patients with these disorders, exactly what nurses are responsible for. So I know you understand your objectives. We will not, I will just state, we're not going to be talking about lead placement and how to read a normal EKG. I will be talking to you about some of the EKG changes, so there'll be some concepts around ECG. However, that will take place. You're going to learn more about EKG readings in 415. Otherwise, these are as stated. So, coronary artery disease encompasses a whole spectrum of things, and I like to look at it on a continuum because I feel as though that's kind of the best way to look at these things. They don't live sort of outside one another. A patient will have risk factors that put them at risk and or help them to develop atherosclerosis. We've already talked about that. You get narrowing of the vessels due to increased plaque buildup inside the blood vessels. You already know the risk factors for that and the patients who have a higher risk for developing atherosclerosis. Then the patient goes on to develop problems with angina. Now, some people don't develop actual chest pain. They may actually have silent angina and may move right into an MI and or acute coronary syndrome. Their sort of term is utilized sort of synonymously, and so forth. When we get into heart failure, we're talking more about complications of MI and acute coronary syndrome type episodes, and we're not going to be getting into heart failure, and then of course death, and hopefully we can help these things to stop from happening. But you understand that CAD, or coronary artery disease, is the most prevalent cardiovascular disease in adults, and it's the leading cause of death in the United States for men and women of all racial and ethnic groups. The risk factors, as you probably remember, diabetes mellitus is one huge risk factor. You'll be learning about diabetes later in the course. The diabetes increases the risk because of what diabetes does to the blood vessels. Uncontrolled diabetes will make blood vessels very stiff and inelastic, as well as sticky. So these little plaques and things can attach twice as readily because they're even stickier. And the other thing is, by making the blood vessels very stiff, when people start to have higher blood pressure, because of the stiff vessels, it also puts them at higher risk for more damage to the endothelial lining. Other risk factors: smoking, sedentary lifestyle, hypertension, high lipids. You can refer to the chart 27-1 on page 731 in your book that has the full range, but those are the major ones. Remember that the 4 modifiable risk factors cited as the major, these things can be altered in any way that we can make a huge difference in terms of coronary artery disease. Elevated LDL, it's the primary target for our cholesterol lowering medications. The Framingham risk calculator, again, look at all the risks as stated by the Framingham risk calculator. So looking at control of hypertension and smoking and blood, all of those kinds of things. Metabolic syndrome, which I'm going to talk about on the next slide, and then this high sensitivity CRP, C-reactive protein, is indicator of, certainly an indicator of inflammatory, increased inflammatory process in the vessels. So, metabolic syndrome is more than a trifecta, a pentafecta, I don't know how to say that, of a person who has hypertension, insulin resistance, meaning, that diabetic tendency, visceral obesity, low HDL cholesterol, and high triglycerides. It consists of 3 or more of those things, so they don't all have to have all of those things. In addition, and that visceral obesity, when they talk about that, they're talking about abdominal obesity. Also having a pro-inflammatory state, so that high C-reactive protein, and also pro-thrombotic state, high fibrinogen levels. So people who tend to be sort of hypercoagulable, they may have some familial tendencies, they may have it may be relative to smoking and some of the other things that create high inflammatory states, which then cause people to be more hypercoagulable. So that is what we talk when we talk about metabolic syndrome. It's a person who has 3 out of the 5 of these factors. They will have a diagnosis of metabolic syndrome, and that is a huge risk factor for coronary artery disease. So angina is sort of that first step into heart disease. Well, second step actually. Atherosclerosis is the first. But angina is pathophysiologically when oxygen supply to the heart muscle is not meeting the demand of the heart muscle. It's usually secondary to atherosclerosis and associated blockage there. So a patient will begin to have chest pain when they're putting more stress on their heart, okay? And so people will have episodes of paroxysmal pain or pressure in the chest, and it's usually because there's insufficient coronary blood flow to deliver enough oxygen to the heart muscle. And there are several different types as listed here. You have stable, which is a predictable and consistent pain that occurs with exertion and is relieved by rest and plus or minus a nitro sublingual tablet. Unstable angina, where symptoms increase in frequency and severity, occur at rest, and may not be relieved by rest and nitroglycerin. Refractory, severe incapacitating chest pain, which means you're probably, until it's diagnosed as acute coronary syndrome or MI, that's probably where you're headed. Variant, which they also call Prinzmetal's angina, which is pain at rest with reversible ST elevation, that's in the EKG, and we'll look at that in a little bit. And it's thought to be caused by coronary artery spasm. A patient doesn't have to have coronary artery disease to have this. They can just have a tendency towards spasm. And then silent ischemia, which is objective evidence of ischemia, either via ECG findings or changes on a stress test, but the patient has had no pain. And we tend to see silent ischemia in diabetic patients and also in the elderly. They don't tend to have the typical heart and angina type symptoms. So just some things to consider. Factors associated with angina episodes. Eating a heavy meal. Is that, again, think about what's going to put more workload on the heart. Exercise and physical exertion, of course, is probably the most common. Cold exposure, and stressful or emotional situations. And so that is our angina in a nutshell. Acute coronary syndrome, heart attack, myocardial infarction, these are all terms that are synonymous. And pathophysiologically, what it means is, and this is, remember, if you look at that continuum from a couple slides ago, this is a step up from that angina, okay? Angina is something that's reversible, generally speaking. When we get to heart attacks and myocardial infarction, there's been some damage. So this is an emergent acute onset of myocardial ischemia resulting in myocardial tissue death or infarction if timely interventions are not employed. I should say that this is not reversible. Reversible is ischemia. Ischemia can be reversed. But once you get to infarction, there has been tissue death, and that cannot be reversed. This spectrum includes that period of unstable angina, where the chest pain is getting more frequent. It's happening when somebody is at rest, so there's no reason really that you can find for the workload to be increased to the heart, and yet the heart is responding that it doesn't have enough oxygen. And then you have your NSTEMI and your STEMI. And what that stands for is non-ST elevation myocardial infarction, or MI, or your ST elevation MI. And we're going to get into those a little bit. So this shows you kind of one way to kind of look at this, another visual, if you will, that you get coronary artery disease. Now, some patients don't ever perceive a chronic stable angina period. They just go straight to acute coronary syndrome, where they have some unstable angina and then are proven to have a non-ST segment elevation MI, or they have an ST elevation MI. It all has to do with, again, how much damage there is. When ischemia is prolonged and not immediately reversible, acute coronary syndrome develops and encompasses this spectrum. And although each remains a distinct diagnosis, this nomenclature, the acute coronary syndrome, really reflects the relationship among these disorders. None of these things are particularly great to have going on, obviously. So here is a vessel occlusion with collateral circulation. What collateral circulation is, and this is, the body is such a great, it's such a great machine, if you will, because, with coronary artery disease, it's usually something that occurs over time, so it's narrowing in a coronary artery over time. So you'll get partial coronary artery closure, and what the body begins to do is to branch out and develop circulation around the blockage. So that's why some people don't ever get to the point where they have a full-blown heart attack, unless they throw a clot or something, really an obstruction occurs, and that completely blocks the vessel. It gets narrower and narrower, and some people, they've developed this great collateral circulation, and they are doing fine with that. Usually people do need some sort of medications to help them through, especially if they try to exercise or walk or what have you. But the body's a pretty amazing thing. And that's why you don't necessarily, sometimes even when stents don't work, we can use medications to open things up enough. It'll open up that collateral circulation. People can live with that, despite having such closures in their vessels. So that's just what this slide is trying to show you. So clinical manifestations. Those two words, clinical manifestations, means is what does your patient look like with these different things? Now again, symptoms are all very similar for these things. You can imagine that the pain and symptomatology for a heart attack, generally speaking, will be worse than that of angina, but they're all within the same spectrum, and I'm going to try to outline how you kind of tell the difference. So clinical manifestations with angina, of course, with all of them, most common manifestation is chest pain. Now there are people who have atypical symptoms, and we'll talk about that in a second, but other associated symptoms people may have, maybe epigastric distress, pain that radiates to the jaw or the left arm, shortness of breath, pallor, meaning paleness, diaphoresis, where they get sweaty. Sometimes they'll have a weakness in the arms, wrists. Oops, I put arms down twice. That must have been twice as important, Anyway, wrists and hands. So just kind of a weird weakness or numbness. Some people will call it numbness. And then there's this sort of less typical syndrome. Women often have this. Also, your diabetics or older people may not have your classic, this classic chest pain, shortness of breath, and up in the arm and all that. They may be short of breath and fatigued with activity. They may have some nausea and vomiting and may have a little discomfort between their shoulder blades, and that's it. So we need to be looking for that. People will often also, other adjectives to describe some of this anginal pain: chest tightness, choking, or a heavy sensation in the chest. And again, it can radiate neck, left arm, shoulders, etc. And sometimes anxiety will accompany the pain. So just something to think about. The pain of stable angina subsides when somebody rests and takes a nitro tablet. They sit down, take a nitro or two, and it goes away. That's usually one nitro. That's stable. Unstable angina is characterized by these symptoms increasing in frequency and severity and not being relieved by that rest or nitro, and requires immediate medical attention. So this just shows you kind of some of the areas where the pain may go. I wanted to just make sure you could see sort of the more classic, that chest pain radiating to the jaw, down the left arm with sweating and nausea and epigastric distress. That's the more common. So again, trying to differentiate. So here's your chronic stable angina. Those symptoms that we talked about: intermittent chest pain, but it's something that often occurs over a long period of time. Sort of has the same look about it to the patient, same pattern, duration, and intensity of symptoms, and it improves with rest and medication, that nitro. Usually 5 to 15 minutes duration. And if you were to put any person who has chronic stable angina on EKG machine, you might see some ST segment depression or T wave inversion that will go away as soon as the pain resolves, as soon as that, they take their nitro and that pain resolves. So that is a temporary kind of thing. These are the kinds of things you will see. It's more or less predictable. Your silent ischemia is one that is sort of picked up almost by accident, because your patient, the big thing with this one is there's a lack of symptoms. Again, associated with diabetic neuropathy. Some elderly people will have silent MIs, and it's confirmed, really picked up by ECG changes, where patients will begin again to have those ST segment depressions and T-wave inversion types of symptoms, which indicate ischemia. Okay, so ST segment depression and T-wave inversion can indicate ischemia. Again, depending on how long it's been, ischemic change can be reversed with medication. Prince-Metal's, that variant angina, that one that occurs due to spasm of the coronary artery, not necessarily associated with coronary artery disease, may or may not be, often seen with patients who have Raynaud's phenomenon or migraine headaches, both of which have a vasospastic type of component, which is why they can sometimes be associated. It's not precipitated by increased demand the way that our chronic angina folks usually are. It just happens, and it usually occurs at rest. And you can see some transient ST segment changes, but again, transient being the operative term here. And then unstable angina. Unstable angina, comparing and contrasting with stable, is rather new onset. It's not predictable. It occurs when somebody's just sitting around doing nothing. It often has a worsening pattern, the pattern being increased frequency. Patient, it can't count on it. It's unpredictable, and it does require medical treatment, emergent medical treatment. Remember, that symptoms in women may be more vague. They may be just having increasing shortness of breath, even at rest, but may not have any chest pain. We still need to think unstable angina. And it is considered a cardiac emergency. Despite, as I was saying, despite the national efforts to increase awareness, women's symptoms continue to go unrecognized as heart-related. But you may, like I said, you may see them having fatigue. They may complain of indigestion or just increased anxiety, interestingly. So it's important for us to be thinking about that this could be cardiac in women, because often when it's not picked up, women go along to have poorer outcomes than men because their syndrome is so different. And then myocardial infarction, acute coronary syndrome, myocardial infarction. This is what your MI will look like. And so what I want you to do once we get through this is to just sort of mull this over in your mind and compare and contrast them. How will you be able to tell the difference? So again, severe immobilizing chest pain. Now, angina can be somewhat immobilizing for people, but it's not relieved by rest or position change or nitrate administration. So with an MI, nitrates are not going to make it better. People complain of heaviness and pressure, burning in their chest, constriction, crushing pain, and often they'll tell you they feel like they've got an elephant sitting on their chest. It can be substernal, retrosternal, or epigastric in terms of its location. Tends to be more common in the morning. Atypical symptoms, obviously, in women and elderly, as well as our diabetics who often have no pain. So just keep those kinds of things in mind, because not everybody has those classic symptoms, and it could just be that shortness of breath. In an older person, they may experience a change in mental status, like confusion or what have you, dizziness, and so it can be very difficult to tell. Some other symptoms. Catecholamine release. Again, which is stimulation. Catecholamines, of course, is epinephrine, norepinephrine. Stimulation, which signifies stimulation of the sympathetic nervous system. Fight or flight, right? Well, this is the body's perception of what's going on. And so it stimulates the sympathetic nervous system to try to encourage more circulation, to get more oxygen to the heart. And so part of the process is release of glycogen and diaphoresis. People will become kind of sweaty, and vasoconstriction of the periphery, because again, the body's trying to preserve circulation to the major organs, the heart being one of them. So people will look kind of ashen or have pallor, be clammy and or cool to the touch in the periphery. Cardiovascularly, they will have initially an increase in heart rate and blood pressure, and then the blood pressure is going to decrease because the cardiac output, as the MI continues, is going to drop. They may develop crackles in their lungs and dyspnea, depending on how much heart failure is going on as a result of this MI. Jugular venous distension, again, it's a sign that the heart is not pumping out well, and so fluids just start to back up. Abnormal heart sounds, S3 or S4, and I gave you some good things in the first lecture, cardiac, to go and review what S3s and S4s signify. It may show up as just a new murmur. And then also with an MI, and you may get this, some people may get this even with their angina or unstable angina, is some nausea and vomiting, because you get a vasovagal reflex, you get the stimulation of that vomiting center because of the severe pain that people have. But certainly with an MI, this is significant. And patients may even have a low-grade fever up to 100.4 in the first 24 hours, which is just, it's consistent with that sort of systemic inflammatory process that is going along with the myocardial cell death. So, I kind of went through the clinical manifestations of an MI before I actually went through the actual patho, figuring that we kind of went over the patho of angina, and it's kind of an extension therein. But I wanted to help you to see sort of the continuum of symptoms, and that they're very similar. They just seem to get worse, and why, and that's why I did it that way. So the patho of our MI, ACS, is they're similar to those of angina. The result of sustained ischemia, which causing irreversible myocardial cell death, which is necrosis. If ischemia goes on for more than 20 minutes, necrosis can result. That's why it's important for us to act so quickly. 80 to 90% of MIs are secondary to a thrombus, of course, with the coronary artery disease narrowing the vessels. And it starts in the subendocardium, so inner, and necrosis of the entire thickness of the myocardium can take 4 to 6 hours, and you'll, with that, lose contractile function. Diagnosis and categorization of MI is based on ECG and analysis of cardiac biomarkers, which we'll get into in class. And so that's what your provider is going to be looking for when the patient comes in. Is they're going to be trying to figure out, do they have an MI going on? Where do they have an MI going on? Etc. So ECG analysis should, as well as those biomarkers, should give you an indicator of whether it's unstable angina, ST segment elevation MI, or a non-ST segment elevation MI. This just shows you an MI from occlusion and kind of what can happen. And this shows you kind of the ischemia, 1 hour versus 8 hours, and how much of the area will infarct over the course of that time. So bottom line, folks, myocardial infarction time is muscle. So ventricular remodeling after acute infarction. This is just, the only reason I put this up was so that you could understand what the heart and what the body does when there has been some sort of an insult. Remember that ischemia is reversible, but infarction is irreversible. So when there has been an infarct, what the body is going to do, there's cell death, and inflammation going on there. So leukocytes infiltrate the area of cell death. And of course, there's proteolytic enzymes in the neutrophils and macrophages, and they try to remove that necrotic tissue even by the 4th day. And during this time, that muscle wall is really thin, as you can well imagine. The necrotic area will be identifiable on ECG by that ST segment elevation, and they'll have a pathologic Q wave. I'll show you this in a little bit. And also they can see it with other scans, nuclear scans, and so forth. But the body, the neutrophils and the monocytes go in and they clear out all the dead debris. And then the body starts to lay down a collagen matrix, which really essentially is scar tissue, to try to offer that area strength. And that's kind of what will happen. In 10 to 14 days, the scar tissue is still pretty weak and vulnerable to stress, so important to know. And so that's why patients will need to be monitored carefully as they increase their activity. Remember that scar tissue it's less compliant. It doesn't stretch as well as the surrounding area, and that could affect the coordination of the heart pumping and the wall function, and how well the atria and the ventricles will work together. So patients may develop arrhythmias, dysrhythmias, if you will, and problems in that result. So the complications of myocardial infarction are these. Dysrhythmias is probably the most common complication, that just for the reasons that I just explained, usually due to that scar tissue and the lack of coordination of the atria and the ventricles after an MI. Heart failure, which occurs when the pumping power of the heart is diminished, cardiogenic shock, when you get a severe left ventricular failure, and then other issues in terms of papillary muscle dysfunction and ventricular aneurysms. So aneurysms, you know, to be a weakness in the vessel wall of the ventricle. So it could be, again, can be very bad things. So I've already answered this question for you, but this is where we're going to take off in class. How does the provider determine what is happening? The patient comes into your emergency room and they're having chest pain. That's it for today. We'll see you in class.